Let's talk about meningitis. And I want to start by saying something that might sound obvious, but it absolutely is not. Meningitis kills people. It kills young people. It kills people who came in looking relatively well, and it kills people when we're slow. So the reason we spend time on this, the reason it comes up again and again in exams and on ward rounds and in emergency departments across the world, is that getting this right matters. Getting it wrong has consequences. Now, what is meningitis at its most fundamental level? It's inflammation of the meninges, those three layers of membrane that wrap around the brain and the spinal cord, the dura, the arachnoid, and the pia mater. When these membranes become inflamed, whether from infection, from cancer, from autoimmune disease, the patient becomes very unwell very quickly, and the brain, which is enclosed in a rigid skull, has nowhere for that swelling to go. That's what makes this dangerous. That's the mechanism underlying everything we're about to discuss. Think about it this way. You've got this vital, incredibly sensitive tissue sitting inside a bony box with essentially no room for expansion. Any infection that reaches those meninges, any inflammation, any increase in intracranial pressure, it's all happening in a closed space. That's the terrifying geography of meningitis. The classic triad. So let's start with what you need to recognize. The classic clinical triad of meningitis, and I want you to know this so well you could say it in your sleep, is fever, headache, and neck stiffness. Fever, headache, neck stiffness. Write that down, tattoo it somewhere, because when those three come together in your patient, meningitis is on your differential until proven otherwise. Now, the neck stiffness, let me explain that, it's called meningismus. When the meninges are inflamed, any movement that stretches or irritates them causes pain. So when you try to flex the patient's neck, bring their chin to their chest, the muscles go into spasm to protect against that movement. That resistance is what you feel. And two clinical signs that test for this are Koenig's sign, where you flex the hip and then try to extend the knee and the patient resists, and Brudzinski's sign, where flexing the neck causes involuntary flexion of the hips and knees. These are classic exam signs. Know them, use them, but also know that they're not always present, especially in the very young, the very old, and the immunocompromised. And here's something important. The full triad, fever, headache, and neck stiffness together, is actually present in fewer than half of patients with bacterial meningitis. So the absence of one of them does not rule it out. If the clinical picture feels like meningitis, you investigate and treat. You do not wait for the textbook triad to complete itself. The red flags I want you to remember are photophobia, sensitivity to light, and altered sensorium. If your patient with a bad headache and fever also can't tolerate the lights being on, and especially if their consciousness is impaired, those are red flags. Those are the signs that tell you this is an emergency. Don't delay. Act. Now, meningitis is not a single disease. It's a syndrome, a collection of features caused by a number of different underlying processes. And for your exams, and more importantly for your patients, you need to know the 5 main types. Let's go through them one by one. Type 1, acute bacterial, pyogenic. This is the one that kills people fastest. When I say acute bacterial meningitis, I want you to immediately think rapid onset, toxic patient, high-risk deterioration. This patient does not look like they've been unwell for a few days. They look terrible. They came in fast and they're getting worse fast. The key organisms depend on the patient in front of you, and this is a classic exam approach. In adults, the two big ones are Streptococcus pneumonia and Neisseria meningitidis. In unvaccinated individuals, Haemophilus influenzae comes into the picture. And don't forget Listeria. This is the organism that specifically targets the elderly and pregnant women. That's a really high-yield fact. An elderly patient with meningitis or a pregnant woman with meningitis, always think Listeria. Now, this is important. The CSF findings in acute bacterial meningitis are distinctive, and you will absolutely be asked about them. When you do a lumbar puncture, you'll see neutrophils, not lymphocytes, neutrophils, elevated in the CSF. The glucose will be low. Why is the glucose low? Because bacteria are metabolizing it. The protein will be high, and the opening pressure when you do the LP will be elevated. Neutrophils up, glucose down, protein up, opening pressure up. That's your bacterial picture. Let me say that again because this comes up in exams constantly. Bacterial meningitis equals neutrophilic pleocytosis. Viral meningitis equals lymphocytic pleocytosis. Glucose is low in bacterial, normal in viral. That single distinction differentiates them in the CSF, and it's tested all the time. Now, diagnosis. Before you start antibiotics, ideally get blood cultures, ideally do a lumbar puncture, and this is a huge, but Never ever delay antibiotics waiting for investigations. If the patient is deteriorating, if they're critically unwell, if there's any delay to the LP, you start antibiotics immediately. The blood cultures give you some information even after antibiotics are started. The lumbar puncture may still be useful, but the window of opportunity for treatment is narrow and you don't gamble with it. Also, before you do an LP, you need to think about whether it's safe. If there are signs of raised intracranial pressure, papilledema on fundoscopy, focal neurological deficits, reduced consciousness, you do a CT head first to rule out a mass effect. Doing an LP in the context of a space-occupying lesion can cause uncal herniation. You don't want to cone a patient who came in walking. So the rule is CT head first if there are focal neurological signs, reduced GCS or papilledema. Treatment, empiric therapy, and by empiric, I mean before you have a definitive culture result, is ceftriaxone or cefotaxime combined with vancomycin. Why vancomycin? Because of penicillin-resistant pneumococcus. And if you're dealing with an elderly patient or a pregnant woman, add ampicillin to cover Listeria, because cephalosporins don't cover Listeria. That's a really important point. Add ampicillin when Listeria is a risk. One more thing about management, dexamethasone. Give dexamethasone with or just before the first dose of antibiotics. It reduces the inflammatory response, it reduces the risk of hearing loss and other complications, and it particularly benefits patients with pneumococcal meningitis. And if you suspect meningococcal disease, droplet precautions, the organism spreads through respiratory secretions. Type 2, tubercular meningitis. Now let's shift gears. Tubercular meningitis is a completely different animal, and the clue to distinguishing it from bacterial meningitis is the tempo. Where bacterial meningitis is explosive, hours to a day or two, TB meningitis is subacute. It smolders. The patient has been unwell for weeks, not hours. They've had low-grade fever, weight loss, night sweats. They've had a gradually worsening headache. And then, crucially, you start seeing cranial nerve palsies. Here's why that happens. TB meningitis characteristically affects the base of the brain, the basal meninges, and that's where all the cranial nerves emerge. So inflammation at the base of the brain directly irritates or compresses those nerves. Subacute onset plus cranial nerve signs. That's the classic exam clue for TB meningitis. If you see that combination, think TB until you can prove otherwise. The CSF picture is different from bacterial. You'll still see elevated protein, actually very elevated protein. You'll still see low glucose, but the cellular response is lymphocytic, not neutrophilic. The opening pressure is elevated. And this pattern, lymphocytes, low glucose, very high protein, is shared with fungal meningitis, which is why distinguishing TB from fungal can be challenging. Context becomes everything. A common complication, and one that often comes up in exams, is hydrocephalus. The basal exudates obstruct the flow of CSF through the ventricular system, and you get obstructive hydrocephalus. If you're imaging a patient with suspected TB meningitis, MRI is your friend. It will show you the basal meningeal enhancement and the hydrocephalus. For diagnosis, the acid-fast stain on CSF is classically taught, but honestly it's low yield. You won't always find the organism on direct smear. Culture takes weeks. PCR is faster and more sensitive. But also look beyond the CSF. Look at the lungs, look at the lymph nodes. TB meningitis rarely exists in isolation. Find TB elsewhere and you've strengthened your diagnosis. Management. Start anti-TB therapy early and start it with steroids. The 4-drug regimen, isoniazid, rifampicin, pyrazinamide, ethambutol, is the backbone. And you treat raised intracranial pressure and hydrocephalus urgently. Untreated hydrocephalus will cause rapid deterioration. Type 3. Viral, aseptic meningitis. The name aseptic meningitis comes from the fact that you won't grow bacteria on your standard cultures, hence aseptic, meaning no bacteria. But there's still a pathogen, and in most cases, it's a virus. The most common culprit by far is the enterovirus family. And here's a clinical pearl. Enteroviruses classically cause summer outbreaks. So if you've got a cluster of young people in summer presenting with meningitic features, think enteroviruses. The clinical course is milder than bacterial. The patient is unwell. They have headache, they may have neck stiffness and photophobia, but they don't look like they're about to die. Vitals are usually stable. They're not the toxic crashing patient of bacterial meningitis. The CSF tells a reassuring story in most cases. Lymphocytes are elevated. Lymphocytic pleocytosis. Glucose is normal because viruses don't consume glucose the way bacteria do. Protein is mildly elevated. Normal glucose in an aseptic meningitis, that's the distinguishing feature. Keep it in mind. Now, there's one virus you absolutely cannot miss in this category. herpes simplex virus, or HSV, and particularly HSV encephalitis, which is when the virus invades the brain tissue itself rather than just the meninges. If you see a patient with temporal lobe symptoms, personality change, bizarre behavior, memory disturbance, or temporal lobe seizures, alarm bells should ring for HSV encephalitis. This is an emergency. Get an MRI, do an LP, and start acyclovir. Do not wait for PCR results before treating. HSV encephalitis treated early has a reasonable outcome. HSV encephalitis untreated is catastrophic. For most viral meningitis cases, management is supportive. Rest, analgesia, antipyretics, fluids, they get better. But always keep your eye on the patient. Altered consciousness, focal neurological signs, seizures, any of those, and you've moved into encephalitis territory, which is a very different beast. Type 4, fungal meningitis. The first thing I want you to do when fungal meningitis crosses your mind is ask yourself, is this patient immunocompromised? Because almost universally, that's the context. HIV infection, especially with a low CD4 count below 100, organ transplant recipients on immunosuppression, patients on long-term high-dose steroids, those are your at-risk patients. The organism you most need to know is Cryptococcus neoformans. Cryptococcal meningitis is the most common cause of fungal meningitis, and it's a significant cause of mortality in HIV-positive patients globally. The clinical course is chronic and subacute, persistent headache, low-grade fever, and a very characteristic feature is markedly raised intracranial pressure, often dramatically elevated opening pressures on lumbar puncture. Why? Because Cryptococcus has this thick polysaccharide capsule that impairs CSF drainage. The pressure builds, and this is clinically important because managing that raised pressure is a critical part of the treatment. Serial lumbar punctures, or a lumbar drain to control it. Papilloedema on fundoscopy in a patient with chronic headache and immunosuppression. Think Cryptococcus. The CSF pattern is similar to TB. Lymphocytes up, glucose down, protein up, opening pressure very elevated. So how do you distinguish fungal from TB? The diagnostic test is the cryptococcal antigen in CSF. This is highly sensitive and specific and is your go-to test. India ink staining may show the encapsulated yeast cells directly, which is quite visually striking when you see it. Those halos around the yeast cells are unforgettable. Treatment has two phases. Induction therapy with amphotericin B plus flucytosine. This is the aggressive phase to reduce fungal burden. Then consolidation and maintenance with fluconazole, which the patient may need to take for a very long time, especially if they remain immunocompromised. Relapse is a real risk in advanced immunosuppression, so long-term maintenance therapy is often required. Type 5. Chronic meningitis is really a category rather than a single disease, and the defining feature is symptoms persisting for more than 4 weeks. When you've got a patient who's been struggling with headache, low-grade fever, and meningitic features for over a month, you need to dramatically broaden your differential. What causes chronic meningitis? Think TB, always top of the list. Think fungal, especially Cryptococcus. Think malignancy, carcinomatous meningitis, where cancer cells seed the leptomeninges. This can come from breast cancer, lung cancer, lymphoma. And then think of the less common but heavily examined causes, sarcoidosis and autoimmune conditions like lupus. The clinical approach is guided by context. You need to know the patient's exposure history and immune status. Where have they been? Have they been in areas where TB is endemic? Do they have any immunosuppression? Any history of malignancy? These questions shape your differential more than any single test. CSF findings tend to show lymphocytic predominance, elevated protein, and glucose that may be low depending on the cause. MRI brain with contrast is important. It may show leptomeningeal enhancement, hydrocephalus, or granulomas, and you may need repeated CSF studies. One normal CSF in a patient you're worried about doesn't rule out chronic meningitis. Repeat the LP. Send targeted tests. TB-PCR, fungal antigen cytology for malignant cells. Management is cause-specific. Treat TB with anti-TB therapy. Treat fungal infection with antifungals. Treat malignant meningitis with appropriate oncological therapy. And always address raised intracranial pressure. It can cause rapid deterioration regardless of the underlying cause. The CSF pattern, your exam lifeline. Let me pull everything together now, because in the exam and at the bedside, the CSF analysis is where you prove the diagnosis, and I'm going to give you a framework you can use for life. Bacterial meningitis, neutrophils elevated, glucose down, protein up, opening pressure up. That's your pyogenic picture. Pus-forming bacteria, neutrophilic response bacteria consuming glucose. TB meningitis, lymphocytes elevated, glucose down, protein very elevated, And I mean very, this is often the highest protein you'll see, opening pressure up. That chronically inflamed picture with a very high protein and low glucose, but lymphocytes tells you to think TB or fungal. Viral meningitis, lymphocytes elevated, glucose normal. This is the key differentiator. Protein only mildly elevated, opening pressure mildly elevated or normal. Normal glucose is the clue. If the glucose is normal in your aseptic meningitis, viral is the most likely cause. Fungal meningitis, lymphocytes elevated, glucose down, protein up, opening pressure often very high, sometimes dramatically so. Similar pattern to TB, but the cryptococcal antigen distinguishes it. Chronic meningitis, usually lymphocytic predominance, glucose can be low depending on the underlying cause, protein elevated. Think broadly when symptoms have been present for over 4 weeks. If you remember only one thing from this entire presentation, remember the CSF glucose. Normal glucose means viral. Low glucose means bacterial, TB, or fungal. That single finding narrows your differential in a moment. Practical decision making. Let me walk you through how I actually think about this at the bedside, because I think it's more useful to see the reasoning than to just memorize the facts. A patient comes in, young adult, headache for 12 hours, getting worse, fever of 39.5, neck is stiff, can't tolerate light. My immediate thought is, this could be bacterial meningitis until I prove otherwise. I'm not waiting. I'm thinking about whether they need a CT head before LP. Is there any papilloedema, any focal signs, any altered consciousness? If not, I go straight to LP after blood cultures. And I start antibiotics within the first hour, not after the LP results come back within the hour. Now here's where people make mistakes. They get the LP result back showing lymphocytes and normal glucose, and they think, great, it's viral, I can relax. But wait, have you thought about HSV? Have you asked about any behavioral change, any memory problems, any temporal lobe symptoms? Has the patient had any seizures? If any of those are present, you start acyclovir and you do an MRI. You don't reassure yourself with the viral picture and miss HSV encephalitis. Another scenario, an HIV positive patient comes in with 3 weeks of headache. The CD4 count is 50. They look chronically unwell. This is cryptococcus until proven otherwise. The opening pressure on LP may be 40 or 50 centimeters of water, dramatically elevated. Cryptococcal antigen in the CSF will clinch it. Start amphotericin B, serial LPs to manage the pressure. This patient needs intensive management. And one more, a patient who emigrated from a TB endemic country. 4 weeks of headache, weight loss, night sweats, 6th nerve palsy on examination, that double vision, that lateral gaze problem, that's a cranial nerve sign, basal meningitis, think TB. Start your 4-drug anti-TB regime even before the culture comes back, because culture takes weeks and this patient cannot wait weeks. Common pitfalls. Let me finish by talking about the mistakes people commonly make because I've seen them happen and I want you to avoid them. Number 1, delaying antibiotics. I've said this already, but I'll say it again because it's the most important pitfall. Every hour of delay in treating bacterial meningitis increases mortality. If you're worried, treat. Don't let an unavailable CT scanner, a delayed LP, or a laboratory backlog delay your antibiotics. Number 2, forgetting Listeria. An elderly patient or a pregnant woman with bacterial meningitis, your empiric cephalosporins don't cover Listeria. If you forget to add ampicillin, you are leaving a potentially lethal organism untreated. This is a classic exam question and a real clinical pitfall. Number 3, reassuring yourself with a viral CSF picture and missing HSV. Normal glucose, lymphocytes, great, it's viral. But you haven't thought about whether this patient has temporal lobe symptoms. HSV encephalitis can look like viral meningitis initially. Think about it every time. Number 4, doing an LP in a patient with signs of raised intracranial pressure. Papilloedema, focal neurological signs, reduced GCS, CT head first, every time. The LP can wait a few minutes for the CT. Herniation cannot be undone. And number 5, missing the chronic presentation. Not every meningitis presents acutely. Symptoms for 4 weeks mean chronic meningitis. Broaden your differential to include TB, fungal, and malignancy. Don't anchor on bacterial meningitis and miss the slow-burning diagnosis. Meningitis is one of those conditions that rewards the clinician who thinks quickly, acts decisively, and stays humble enough to consider the full differential. The rapid, toxic presentation of bacterial meningitis demands urgency. The smoldering subacute course of TB meningitis demands thoroughness. The immunocompromised patient with chronic headache demands a specific mindset. Know your CSF patterns, know your organisms by patient group, know when to treat empirically without waiting, know which organisms your standard antibiotics don't cover, and always, always take the headache seriously in a febrile patient. Fever plus headache plus neck stiffness, that's your alarm and you should respond to it every time. This is one of those topics where knowledge genuinely saves lives, not in an abstract sense and in the real, specific, named patient in front of you sense. So learn it well, apply it rigorously, and never let complacency creep in. Thank you.